Hello, my name is Ian Cole, and this is another video from the Dermatopathology Made Simple series. Today we're going to talk about Lentigo Maligna. Now, Lentigo Maligna we commonly see in elderly individuals, and with most people living a lot longer in a country such as Australia, you're starting to see patients with a whole mixture of areas of pigmentation on their face. Sometimes these are simple solar lentigos, and generally they have a fairly uniform skin color. But once you start to get variable pigmentation within a lesion, then you have to think about Lentigo Maligna. Lentigo Maligna is basically just melanoma in situ. And the fact that it's in situ indicates that the abnormality is restricted to the dermoepidermal junction. There's no invasion into the dermis at all. There may be spread down hair follicles, but really the lining of a hair follicle is contiguous with the surface epidermis anyway. So this is what makes it all in situ. What we'll do now is have a little look at the histopathology of this. First of all, let's have a little look at the clinical. Here's a Lentigo Maligna. You can see variable pigmentation in this area here. You can almost see what looks like a lines reticular here, but in point of fact, these are follicles, and this is perifollicular pigmentation that you're seeing. The lesion actually extends all the way right round here. When you have a look at this with a dermatoscope, then this is the picture that you see. Now, we don't usually describe this as lines reticular. You can, because they're circles, but they're really gray circles, and the circles are touching in areas. And you've got areas of pigmentation in the spaces in between the follicles. As Lentigo Maligna progresses, these areas of pigmentation can extend to such an extent that they'll remove the actual follicular openings, and you'll just get a black mass. It's black because the pigment's fairly high in the epidermis itself. However, one of the, if you're looking at this from a differential point of view, it would be difficult to separate out pigmented solar keratosis, for instance. And this is why a biopsy is often essential. And generally, a shave biopsy is better than a punch biopsy because you're going to sample a much larger area. And the pathologist needs a fairly large area to really get a handle on this, as you'll see in some of the histological specimens we're going to show you in a minute. Let's just flick back to this. If we're looking at histopathology, there's a lentiginous proliferation of single atypical melanocytes along the dermoepidermal junction and down the sides, the infundibulum of hair follicles. There can be some nesting, but it's not marked at all. There's usually no upward spread of atypical melanocytes. Again, you can get a little bit of focal upward spread, and we'll show you that. But you don't have the gross pagetoid spread that you'll see in a superficial spreading melanoma. And this is the other little thing. Because these lesions are usually seen on sun-exposed areas, there's considerable solar elastinosis. And because of the chronic sun damage, the overlying epidermis is often atrophic. Before we have a look at histopathology, let's look at another case. Here's an area of pigmentation on the lateral surface of a man's face, just on the lateral epicanthus here extending out from the eye. Again, you can see the varying pigmentation that we're seeing here within this. And when you have a look at it with the dermatoscope, again, this time you're seeing some brown circles, some obliteration of the circles in this area here with the spread of pigment. This area here, difficult to differentiate that perhaps from a solar lentigo, and hence this is where the biopsying bit is important. You've got the biopsy by taking a larger area or biopsying in this area here where you see the most significant change dermatoscopically. Time for some histopathology. In this particular case, you've still got quite an intact epidermis here. It's not really all that thin. What you do have, though, is a lentiginous proliferation of atypical melanocytes along the sides of the retiridges that are here. There is a bit of melanin here in melanophages in the dermis, and there's a bit of a lymphocytic infiltrate here as well. And if we look at a close-up, again, just highlighting this lentiginous proliferation of atypical melanocytes. They usually have an enlarged hyperchromatic atypical nucleus and a bit of clear cytoplasm. And it's always in the basal layer that you in fact see them. Here you've got a little bit of upward spread, very focal, very little area. Here you've got quite a marked lymphocytic infiltrate. Here you've got some melanin and melanophages, indicating there's been a bit of an attack of the lymphocytes on the melanocytes here, and some have disgorged their melanin into melanophages in the dermis. Here's another more florid Lentigo Maligna on an ear. You can see the very much darker pigmentation here. You can see the extent of this, so it's all the way right out here. And if you put the dermatoscope on it, then here again you've got brown or black circles, you've got perifollicular pigmentation, and here the follicular openings are being virtually obliterated. Here's another example on a scalp. This went quite some time undiagnosed. Here we've shaved the hair away so that you can see this. You can see the varying pigmentation within this. And really it would depend on where you biopsied this as to the histopathology you might see. Let me show you the histopathology of this particular case. And perhaps it shows some of the more common features that you're going to see in a Lentigo Maligna. Here you've got this flattened or thinned epidermis. And this blue material you're seeing here, this is solar elastosis. This is chronic sun damage changing the collagen and elastic tissue. Here you've got some brown melanin and melanophages. And what we're trying to show there is a little atypical proliferation or a proliferation of atypical melanocytes at the dermo-epidermal junction. Now if we look at a higher point view, here you see it here. Now, you may look at this and think that really the proliferation isn't that marked at all. And you need to look at the whole specimen to get a feel for this particular proliferation. You've got little bits of lymphocytic infiltrate. It's always worthwhile if you're looking at a slide to look wherever you see the lymphocytes, because it generally indicates there's a bit of activity and immune activity occurring. And if we look at this other view here, you can see there's very little nesting. It tends to be a proliferation of atypical, single atypical melanocytes. Now the question is that upward spread, or is it just an atypical keratinocyte? And sometimes it can be quite difficult to tell here. This is your solar elastosis. This is your melanin and melanophages in the dermis. But as I say, and here you've got some increased melanin in the keratinocytes here. And this would correlate with some of the deeper areas of pigmentation that we were seeing clinically. If we just go back and look at that again, it would correlate with some of the deeper areas of pigmentation here. When you've got a thinned epidermis like this, even basal, increase in basal melanin can look black because it's so thin. If you had a thicker epidermis, it would look brown. Normally melanin at the dermo-epidermal junction is brown. It's usually only when it's higher up that it's black, but it depends on how thick, how many layers of keratinocytes there actually are in that epidermis. And in this guy, it's thinned quite significantly. So if we look back again at this histopathology, I haven't really shown some hair follicles there to show the spread of this down a hair follicle, but that's one of the features of Lentigo Maligna. And as I said, the focal transepidermal migration of the melanocytes, and the irregular distribution of the melanocytes, the atypical melanocytes along the thinned epidermis here. If you're looking at differential diagnoses of Lentigo Maligna, then what about Lentigo Maligna melanoma? Well, that's all the features of Lentigo Maligna, but you're also going to get some degree of dermal invasion, and it's essentially the same as superficial spreading melanoma. Follicular melanoma, some people think melanomas, Lentigo Maligna, may arise from the follicles and the cells. Atypical melanocytes spread up from stem cells there into the overlying epidermis, and this may in fact be the case. If you've got a superficial spreading melanoma, we've said that generally there's much more upward spread, much more pagetoid spread of melanocytes in atypical melanocytes, and there's less of this epidermal atrophy. But Lentigo Maligna, you get the epidermal atrophy because it's mainly in chronically sun-damaged skin. And sometimes, with superficial spreading, if it's on a covered area of the body, you won't get that underlying solar elastosis either. Acrolentiginous melanomas, they also can have scattered junctional melanocytes, but usually they're restricted to the ridges, and that's why you have the parallel ridge pattern when you're looking at it with a dermatoscope. And usually, again, the overlying epidermis in an acrolentiginous melanoma is going to be acanthotic. It's going to be thickened. The palms of the hands, soles of the feet, the skin is going to be thickened in those areas. And again, there'll be this lack of solar elastosis. With a solar lentigo, then you tend to have retiridges in those areas, and they're elongated, and you have pigmentation at the base of those retiridges. And generally, there's little or no increase in melanocytes at all. And the last one that we talked about was clinically going back to this case, and I said this could be just a pigmented actinic keratosis. But if that's the case, you're going to have atypical hyperpigmented keratinocytes in the lower third of the epidermis, and there shouldn't be any increase in melanocytes. So, to go back again, these are the features of a typical Lentigo Maligna. Atypical melanocytes, singly or very few nests, very little in the way of upward spread, solar elastosis, and spread of the atypical melanocytes down a hair follicle. If you see those features, then you're seeing the features of Lentigo Maligna. Thank you very much.